Hello, and welcome to the ASCO Daily News Podcast. I'm your guest host, Dr. Diwakar Davar, and I'm an Associate Professor of Medicine and the Clinical Director of the Melanoma and Skin Cancer Program at the University of Pittsburgh's Hillman Cancer Center. I'm delighted to welcome my colleague and friend, Dr. Jason Luke. Dr. Luke is an Associate Professor of Medicine and the Director of the Cancer Immunotherapeutic Center at the University of Pittsburgh's Hillman Cancer Center. He is a very, very well-renowned physician scientist who has done fundamental work in developmental therapeutics and also in melanoma. Today, we'll be discussing some key oral abstracts highlighting advances in immunotherapy in the cutaneous malignancy space that will be featured at the 2023 ASCO Annual Meeting. You'll find our full disclosures in the transcript of this episode, and the disclosures of all guests on the ASCO Daily News Podcast are available on transcripts at asco.org/dnpod. Jason, thank you for coming on the podcast today.
Well, thanks so much for the opportunity.
So we will go right ahead into the abstracts. And the first one we thought we'd discuss is Abstract 9502, which is the Relativity-047 study, specifically the 2-year results. This is the update. This has also been concurrently published at the New England Journal Evidence Journal Online. And so in this publication and oral presentation, Hussein Taubi, Georgina Long, and colleagues are talking about the Nivorella data in the context of metastatic melanoma. So what is your take on this? What is your take on the data, both presented and published? And how would you contextualize this for the audience?
Right. So the Relativity-047 study, as people will remember, randomized treatment-naive patients with metastatic melanoma to either receive nivolumab as standard treatment as a monotherapy, or the combination of nivolumab and the anti-LAG3 antibody relatlimab. And that study reported out a couple of years ago showing the improvement in progression-free survival as the primary endpoint. And at the time, we saw that difference was approximately a 6-month absolute difference. And eventually, we saw there was an increase in the overall response rate also, again, approximately on the order of about a 10% change. What was interesting was that the overall survival initially was immature, and that was an interesting follow-up point that we wanted to see. So I think what's important in seeing now this 2-year update of these data are the maintenance of the benefit for nivolumab plus relatlimab as compared to nivolumab alone across those measurements of progression-free survival and overall response rate. Interestingly, the overall survival in the clinical trial actually did not meet the pre-specified threshold for statistical significance. That being said, when you look at the data presented in the Kaplan-Meier plots and you think about the difference, it really does appear that there's a clinically meaningful difference between these two groups. And the statistical cut point only missed by about 0.01. And so this is one of those areas where one wonders whether or not subsequent therapies may have impacted on the overall survival calculation, because obviously patients in this trial had not received ipilimumab or a PD-1 CTLA-4 combination. So the take-home message from me in these data set was that the benefit of nivolumab and relatlimab was sustained over time, and there was no suggestion of any late toxicities that might make us concerned. One advantage of this combination of nivolumab and relatlimab is the dramatically improved side effect profile relative to nivolumab and ipilimumab. So whereas immune-related adverse events that were serious, grade 3 or 4, is approximately 50% for nivolumab and ipilimumab, in the Relativity-047 study, we see that the incidence of grade 3-4 toxicities for nivolumab and relatlimab is 17.2%. So that's less than half. So that's pretty attractive. And when we think about, frontline management of patients, I think these data really support that nivolumab plus relatlimab is a reasonable consideration for some patients. And now I think the future question is really going to be, okay, well then who should get nivolumab and relatlimab versus who should still get nivolumab plus ipilimumab? Obviously, these data do not address that. And I think that's probably the most important question for metastatic disease that's probably on the horizon.
Thank you, Jason. Those are all, fantastic points. It is interesting to note that as a result of the data, or really the lack thereof, the combination is actually not being launched in certain countries. So, for example, the German Health Authority, GBA, the Federal Joint Committee in Germany, has decided against the acceptance of this agent because it does not accept PFS as a patient-relevant endpoint. So it's interesting that we have an agent that is now going to be FDA approved. It's already FDA approved and available in the United States, but it will not be at least available in Germany. And there may be other countries that decide favorably or unfavorably, depending on how this OS data is viewed. So pivoting to another LAG3 inhibitor, in this case fianlimab, we're going to discuss Abstract 9501. So Abstract 9501 essentially is describing a phase 2 trial that evaluated the LAG3 inhibitor fianlimab along with the anti-PD-1 inhibitor cemiplimab from Regeneron. The data is slightly different from what we have seen with Relativity-047, the Opdualag combination. So Jason, how would you contextualize the fian-semi combination in advanced melanoma in the context of what we've seen with Relativity-047? If you could help us with that, please.
Yeah, absolutely. So before we dive into this specific abstract, it's like you mentioned, probably useful to just put all of this in context. Targeting LAG3 as an immunomodulatory approach actually has been in clinic for a decade approximately. And so the relatlimab phase 1 started quite a long time ago. And there was data for nivolumab and relatlimab in PD-1 refractory patients with melanoma that showed, not a tremendously obvious level of activity. And so it was thought there that the only place they would see that activity was to go to a frontline randomized phase 2 and then phase 3 trial, as we just discussed. In contrast to that, given all the data that had come forward about LAG3 targeting with relatlimab, the group developing fianlimab took a different approach and rather treated a cohort of patients with treatment-naive melanoma to try to get an initial assessment right away of the activity as read out by overall response rate for this PD-1 plus LAG3 combination, which is cemiplimab plus fianlimab. And these authors have previously presented data about this combination from cohorts of patients who are treatment naive who received this combination and described approximately a 64% overall response rate. And that's an impressive number in the treatment naive setting. There's sort of a tension there to sort of say, well, wait a minute, the response rate in this single arm study is 64%, but in the Relativity-047, the response rate was lower for the LAG3 combination. And I think that's not a fair comparison. We have to realize this is a much smaller group of patients that has the potential to have been somewhat biased towards a better cohort just because of where and when they were recruited to participate in this trial. All the same, I think that number does look impressive and suggests that this combination is active in the front line. Specific to this abstract, though, what the authors presented here was to update those previous data and then specifically also to focus on a cohort of patients who are allowed to have had previous treatment in the perioperative setting, so either neoadjuvant or adjuvant therapies. And in a subgroup of patients, they observed that even in the patients that had received adjuvant anti-PD-1, who went on to then progress later, they got actually a similar overall response rate at approximately 60%, even in that group. And so I think that seems like an exciting number as well. One would, on first principles, think that if patients got an adjuvant anti-PD-1, that then a PD-1 LAG3 combo could be less active. When and how the patients progressed or did not on that adjuvant therapy, however, I think makes a big difference. And given the relatively small sample size of patients that were included in this report, which is on the order of 20-ish patients who were in the previous PD-1 treated adjuvant cohort, I don't know that we can make super broad analyses trying to compare across the development programs. What I would take from this abstract, however, is that it does appear that this other PD-1 LAG3 combination, cemiplimab plus fianlimab, is also very active. It certainly deserves to be investigated in similar clinical trial contexts as the nivolumab plus relatlimab combination that we previously discussed. And while it's not specifically stated here, that is happening. There is a frontline phase 3 trial for this combination of fianlimab and cemiplimab, as well as adjuvant considerations also ongoing.
So thank you. So that we've seen a lot of LAG3 data this last 2 months. The phase 1, phase 2A Relativity-020 trial has just been published in the JCO. Encourage people to read that. And so that was the evaluation of nivo and relatlimab in the post-PD-1 patient population that Jason alluded to, where the response rate that was observed was 12%. So we've seen a lot of interesting data, a lot of interesting survival data, and now a new potential combination with LAG-3 with fianlimab and cemiplimab from Regeneron. So it'll be a very interesting next couple of years as we see whether or not this new combination, how it shakes up against the established nivo-rela combination, again, albeit with the limitations of cross-trial comparisons, and also how it performs against cemiplimab in this ongoing, as you alluded to, ongoing global phase 3 trial. So pivoting away from melanoma, now addressing the context of another cutaneous malignancy, a very high risk one, Merkel cell carcinoma. So Merkel cell carcinoma, for those who are not necessarily treating a lot of this, is a very rare and very aggressive cutaneous tumor. It's a neuroendocrine tumor of the skin. It's a cancer that's typically associated more than about 60% of the time with a cancer-causing virus, an oncogenic virus known as a Merkel cell polyomavirus. And in this setting, checkpoint inhibitor therapy has been approved for the last couple of years, initially with a PD-L1 inhibitor, avelumab, and then more recently with a PD-1 inhibitor, pembrolizumab. And at this point in time, there are 3 FDA-approved agents that are checkpoint inhibitors that are available for the treatment of this disease. And CheckMate-038 was essentially a trial of nivolumab plus minus ipilimumab in the setting of this Merkel cell carcinoma. So, Jason, what are your thoughts on how the addition of IPI did in this setting?
Yeah, so I think this is a really interesting abstract because there's a slightly more context even than what you alluded to there. This study is a open label, multi-cohort, but single arm investigation where one cohort of patients received nivolumab alone and the other cohort received ipilimumab. It needs to be buttressed by a previous publication in the Lancet last year by the group at the Moffitt Cancer Center, who also did a prospective study looking at nivolumab and ipilimumab. In that previous study that the Moffitt group did, they found a response rate of 100%. All patients responded to the combination of nivolumab and ipilimumab in their study. And that was quite provocative, suggesting that while anti-PD-1 alone has about a 50% response rate, adding IPI in that scenario then took it to 100. So these data were very much of interest because this could be a confirmatory data set to suggest for this rare tumor that perhaps a combination regimen should be preferred. Of course, one has to remember that adding ipilimumab to anti-PD-1 substantially enhances the toxicity profile. And these patients tend to be elderly that develop this kind of cancer, Merkel cell carcinoma. So that's a rather important caveat. Just to get to the crux of what happened in this trial, as opposed to the previous Moffitt trial, there actually did not appear to be a major increase in the benefit of adding ipilimumab, at least in this trial. Because again, in parallel cohorts, the nivo monotherapy arm had a 60% response rate, which is roughly a little bit higher, but roughly in line with what we've seen previously. And the response rate to nivolumab plus ipilimumab was 58%. So I mean, basically the same. So how can it be then that we have this previous very high profile publication that says 100% response? Now we have a second publication that says adding IPI doesn't do anything. That's confusing. And I think it'll be really, really important to try to look at what were the differences between these two cohorts of patients. Did one of them have higher risk features, greater disease burden, et cetera? We don't really know that just yet, but trying to tease that out will be important. This data also emphasized, though, the complexity around dosing of ipilimumab. And in melanoma, we never really figured out what the best dose of ipilimumab was to give, either alone or even in combination with a PD-1. And we don't really have time to get into all of it right away here, but there are multiple studies in melanoma that would suggest that giving IPI on an every 3-week dosing schedule is superior to giving it on a 6-week dosing schedule. In this study, they did use the 6-week dosing schedule. So whether or not that could have made a difference, I guess, is unknown. But I would notice that in the previous Moffitt trial, they also used that 6-week dosing schedule. This one's a head scratcher for why did these data not confirm a previous data set? But for the time being, I think this emphasizes that PD-1 monotherapy really is the standard approach that should be considered for patients with metastatic Merkel cell carcinoma.
That's great, Jason. And so again, it's a very tough patient population. These are very rare patients. The Moffitt trial that Jason alluded to essentially was a trial that had, in each arm, there were approximately 25 patients, of which 13 or between 11 to 13 patients were actually checkpoint inhibitor naive, wherein the dramatic 100% response rate was seen. And this is a trial where, at least in this update, we've got about 25 patients in nivo monotherapy arm and 43 patients. And so in a disease that is, thought to be extraordinarily sensitive to checkpoint inhibitor immunotherapy because of the role of the virus and the high TMB that it's associated with, it is very interesting that the addition of an additional checkpoint inhibitor did not appear to improve outcomes, but as you alluded to, multiple reasons, but we don't know how it's going to shake out. Next abstract, 9507, and this is a very interesting trial known as the Matisse trial. So in the context of cutaneous squamous cell carcinoma is a relatively not uncommon cancer, primarily seen in older cancer patients, particularly a little bit more common in men. And in this setting, we've got checkpoint inhibitor therapy that is FDA approved, at least two of which are FDA approved right now, pembrolizumab and cemiplimab. Both were approved in the advanced cancer setting. And we do know that because of the extraordinarily high tumor mutation burden associated with cutaneous squamous cell carcinoma, checkpoint inhibitor therapy has got very dramatic effect. Response rates of between 35 to 42% with pembrolizumab and 40 to 50% with cemiplimab, depending on whether or not one looks at the relapsed metastatic or the locally advanced patient populations. And interestingly, much like we've seen with, melanoma, we have migrated the use of this therapy early in the lines of patients, particularly in the setting of perioperative therapy. So, Jason, how would you contextualize the results of the Matisse trial in relation to the existing and known data from several of our colleagues regarding the role of what checkpoint inhibitor therapy is doing in terms of quote unquote organ preservation?
Yeah, and I think this is an area of tremendous excitement. And as you were alluding to, the activity of anti-PD-1 really was transformative in this disease, which really can be a disfiguring and locally destructive disease. And with that activity for unresectable disease, last year, near the end of the year, there was a first report of a large neoadjuvant clinical trial in cutaneous squam, which showed really outstanding results in terms of improving surgery and pathologic complete response using anti-PD-1 in that setting. And for this trial, this was a trial done in Europe, they took a similar tact of trying to think about giving anti-PD-1 or anti-PD-1 with anti-CTLA-4 with ipilimumab in that neoadjuvant period to see whether or not they could reduce the use of extensive surgery and or radiation therapy. The short version is they were able to do that. And so they described 40% of patients with single agent anti-PD-1 and 53% of patients who received that combination having major pathologic response to treatment. And this was so much so that 10 of the patients who had pathologic responses actually withdrew their consent to go on to have surgery because they decided that they had such a good effect of the immunotherapy, they weren't willing to put themselves through what was going to be a very difficult surgery. And I think that speaks to the upside potential of these checkpoint immunotherapy approaches in certain settings, specifically here in cutaneous squamous cell carcinoma. Moreover, they described clinical response in the neoadjuvant setting as 50% for PD-1 monotherapy and 61% for the combination. And I really think that this is really ready for prime time. With the study published in the New England Journal last year and these data now, I really think the field needs to start moving towards the use of perioperative anti-PD-1 with or without ipilimumab as a standard approach. And I think it's the case that even the NCCN and ASCO and various guideline societies are going to start acknowledging that this ought to be considered for most patients who are facing difficult surgical operations for cutaneous squamous cell carcinoma.
So, Jason, you bring up a fascinating point, which is the appearance of this in guidelines. So this is undoubtedly extraordinarily good data. It's confirmatory. The pathologic response rates, in many ways paradoxically low. You'd expect something about 50% or so, but the reason it's low is because 10% of patients who actually benefited didn't undergo surgery. So really, the degree of benefit is tremendous. It's about 50 to 60%. So the fascinating thing in this setting that we'd have is if one is going to try to get the drug FDA approved, What we now have is the conventional setting in which one needs a definitive endpoint, and at least we know that pathological response rate is not a definitive endpoint in the context of melanoma or for that matter cutaneous squamous cell carcinoma. The only setting in which it is a regulatory endpoint is a non-small cell lung cancer or triple negative breast cancer. But recently, there's been some very exciting data from another PD-1 inhibitor called dostarlimab in a trial done by your former colleague, Dr. Luis Diaz, when he demonstrated a dramatic result of dostarlimab in the context of perioperative rectal cancer, that is microsatellite high, wherein the standard of care is typically very disfiguring abdominal perineal resection. So, in the context of some of our listeners who might be thinking a little bit about how this pertains to regulatory approval, what are your thoughts about the paradigm of avoiding highly disfiguring surgery, relating what was seen in the rectal cancer discussion to what we are now seeing with perioperative therapy in the context of cutaneous squamous cell carcinoma?
I think it's a very important question. And the easy out for diseases that have a pattern of progression that is metastasis is to use event-free survival, which can include both the pre-surgical and the post-surgical period in terms of looking for whether or not the cancer comes back. And that works for diseases potentially like lung cancer, like you said, maybe melanoma. In cutaneous squamous cell carcinoma, however, that's not probably going to work because this tends to be a locally invasive and less of a metastatic disease. So here then we really need to have sort of organization across patient advocacy, dermatology, medical oncology to come up with what the most appropriate considerations are going to be for evaluating that long-term benefit. Because I think we need a tangible result that we can show the FDA. Everyone is really impressed by these results. And I think that next step is to craft this into a way that we have a measurable output that we can then go to them with and say, bless this so that all of our patients can get this kind of treatment.
Really great discussion, Jason. And I think this is going to be an area of particular interest going forward, given both the number of trials that are being conducted in this space and also the role of the very interesting regulatory paradigm that has now been set initially, at least with the rectal cancer, that is microsatellite high, and now potentially we will see with cutaneous squamous cell carcinoma. And so the final abstract that we have selected for you is abstract 9511. And this is a trial that was conducted by a mutual colleague, Dr. Ryan Sullivan, and his colleagues. And it's essentially a trial of looking at targeted therapy with or without navitoclax in BRAF mutant melanoma patients. And part of the reason to highlight this, it's a very interesting preclinical data supporting the addition of navitoclax, but also a great example of a early trial that came through the CTEP portfolio. And so, Jason, can you tell us about why this is exciting and how we might contextualize the addition of navitoclax to the targeted therapy backbone?
Sure. So listeners will be quite aware of targeting mutant BRAF as a therapeutic strategy across oncology. That was really initially pioneered in melanoma with the development of vemurafenib as the first selective BRAF inhibitor. But the field, of course, moved eventually to BRAF and MEK combinations across essentially all settings. We know that dabrafenib and trametinib are now approved pan-cancer for anywhere we find a BRAF V600E mutation. In the context of melanoma, looking at mechanisms of resistance, we observed that they were quite heterogeneous with reactivation of elements of the mitogen activated protein kinase pathway, the MAPK pathway. But also there were metabolic changes in the cancer cells themselves, which could drive resistance and were downstream of some of those reactivation signaling points. So one of those is the induction of anti-apoptotic machinery in the cell. So activation of BCL2 or BCLXL to try to save those melanoma cells when they were under stress by blockade with BRAF and MEK inhibitors. And that observation was made now about a decade ago or more. And that raised the possibility that repurposing a drug that was being used actually in the heme malignancy space might be useful in augmenting targeted therapy. And that's where we come in with the navitoclax as a BH3 mimetic that can actually knock down those anti-apoptotic proteins, BCL2, BCLXL. And so that was the context for this initially phase 1 clinical trial of combining navitoclax with dabrafenib and trametinib. And those data supported the safety of doing that and moved to this study, which was a randomized phase 2 study of that triplet regimen versus dabrafenib and trametinib alone. And so this study started quite a long time ago, before the sort of initiation or widespread use of anti-PD-1 antibodies. And so it had to kind of undergo some various iterations throughout its course, but eventually has now read out, and it had two primary endpoints, with one being focused on improving the complete response rate for targeted therapy, because that's been associated with long-term outcomes, as well as to look at the maximum tumor shrinkage of patients within this trial, and of course to look at other endpoints like response rate, progression-free survival, et cetera. About half the patients who participated in the trial had prior immune checkpoint blockade, and they were actually distributed evenly across the two arms, so we think that probably won't impact on the outcomes. And what was observed in the clinical trial was that, in fact, the triplet did improve the complete response rate for targeted therapy. So navitoclax plus dabrafenib and trametinib had a complete response rate of 20% versus dabrafenib and trametinib alone being at 15%. Both of them had an overall response rate in the 80% range, with slightly higher for the triplet at 84% versus 80% for the doublet standard therapy. There was also suggestion that there may be a disproportionate benefit for the triplet actually in patients with smaller baseline tumors. And we know that the efficacy of targeted therapy is more pronounced in the lower volume disease state. And so overall, when we look at this, without really adding much toxicity, I think this is an intriguing place to look at further drug development. BRAF and MEK inhibition has been a backbone therapy in melanoma for a long time, but we really haven't been able to move past it or augment it in any real way because of the heterogeneity of treatment resistance. And here, by going after metabolic changes, we perhaps might have the opportunity to enhance our targeted therapy somewhat further. And so we'll look forward to further results investigating this regimen in subsequent clinical trials.
Fantastic discussion, Jason. So these are all great insights. As you've heard, we've now discussed a couple of key abstracts covering major topics that will be presented, major themes of the malignancy space at ASCO 2023, including the addition of a LAG-3 inhibitor to checkpoint in both randomized large phase 3 trial and a smaller phase 2 trial, the context of targeted therapy in melanoma, making another forerun in the post-DREAMseq setting, and two very interesting studies that have looked at checkpoint inhibitor therapy in the context of cutaneous squamous cell carcinoma and Merkel cell carcinoma, addressing themes that are huge importance going forward, including the role of perioperative therapy in squam and the addition of a CTLA-4 inhibitor in Merkel. These abstracts are all going to be discussed and going to be presented in the oral abstract session at ASCO, and we look forward to seeing you there. So thank you, Jason, for taking the time to join us and for highlighting these important advances in immunotherapy. And thank you to our listeners for your time today. You will find links to the abstracts discussed today in the transcript of this episode. And finally, if you value the insights that you hear on the ASCO Daily News Podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts. Thank you for your attention.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Well, thanks so much for the opportunity to participate today.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.